Assalamu alaikum. I am Dr. Abdurrahman Muhammad Alam. Welcome to today's cataract surgery insights on posterior polar cataract. I am sitting temporarily. Make a side port inferiorly and superiorly with a 15-degree steel knife. Now stain the anterior capsule with Trypan blue. Wait for few seconds, then wash out the Trypan blue. Now I am washing out the Trypan blue with BSS. Deepen the AC with OVD before making the main wound. I'm making the main port with a 2.4 steel keratome. Deepen the AC with OVD and cover the corneal anterior surface with OVD. Now start with the creation of the CCC of 5 mm. In posterior polar cataract, the rhexis should be of adequate size, should not be big or should not extend, because posterior polar cataract has an inherently higher propensity for posterior capsule rupture and nucleus drop during cataract surgery. In that case, you need to have an intact capsulorhexis and of adequate size for placement of a multipiece IOL in the sulcus with optic capture, or a PMMA IOL placement in the sulcus. After completion of the rhexis, gently remove the rhexis by pressing the lower lip and passing a little bit of BSS. Then commence with hydrodelineation. Hydrodissection should be avoided because with hydrodissection PCT may occur. The golden ring is formed after hydrodelineation can be easily seen. Now perform mechanical cortical cleavage dissection with a ball chopper, since hydrodissection is contraindicated in posterior polar cataract as it can lead to posterior capsular rupture. How MCCD is performed? Take the ball chopper around the equator and pass it around the equator of the nucleus. In doing so, you will achieve a good cortical cleavage like hydrodissection. Now I'll perform pre-phaco in continuous mode with power at 30%, bottle height at 80 cm, AFR at 30 cc per minute, and vacuum at 185 mm of mercury. Now in my sculpt mode, I'll groove out a V pattern groove. V pattern groove is done so that when I am cracking the nucleus, there will be less stress given in the posterior center part of the capsule where the posterior polar cataract is situated. Now I'm cracking the groove. Now I'm performing a horizontal chop to separate that wedge of nucleus. It is successfully separated. Also, rotation of the nucleus is achieved because I have done a successful MCCD. Now I'm performing another horizontal chop. Yes. Now I have 3 pieces in the bag. I can chop it. Now I have 4 pieces. Now I'll remove these pieces with quadrant mode. You can see my quadrant setting in the left hand corner. I like to use burst mode. I'm slowly chopping the pieces and removing it in quadrant mode. Slowly, all the piece of the nucleus is removed. Only remaining part will be the epinucleus. The epinucleus will be removed by epinucleus mode. After removal of the piece, we can easily see the posterior polar cataract situated posteriorly in the center part. In my epinucleus mode, I am removing the epinucleus. I'm also using a burst mode to remove the epinucleus. With the removal of the epinucleus, the posterior polar opacity, the posterior polar cataract also gets dislodged and is aspirated out in the epinucleus mode. See, it is the posterior polar cataract is also being removed by the epinucleus mode. Yes, the epinucleus is removed along with the posterior polar cataract. Now perform viscofluid exchange when coming out. Now remove the cortex with a straight tip coaxial handpiece. My cortex setting is bottle height of 80 cm, AFR of 28 and vacuum of 320 mm of mercury. In posterior polar cataract, always remember to do viscofluid exchange when coming out because any instability of the anterior chamber may lead to PCT in the posterior capsule. Because the posterior capsule in posterior polar cataract is invariably weak. Now I'll increase the main port to 2.8 mm. Again, I'll form the anterior chamber with OVD. I'll push OVD into the posterior capsule to open it up, which will help me in placing the IOL in the posterior chamber bag. Now you can see me loading the IOL in the Monarch butterfly cartridge. Now gently press the nozzle of the cartridge and inject the IOL into the posterior chamber bag. With the help of the spatula, I dial the IOL into the posterior chamber bag. Now remove all the visco that was injected into the eye. Removal of the OVD from behind the lens should be done gently because you can induce a PCT. Polishing of the weak, fragile posterior capsule of the posterior polar cataract is avoided because it can be easily lead to a PCT to occur. At the end of the surgery, hydrate the wound with stromal hydration and give intracameral antibiotic and subconjunctival dexamethasone, and the case is completed. Hope today's cataract surgery insight video was helpful in developing your surgical skills. Thank you and take care, my dear friends.